Hello, friends. Welcome back to Block On. Thanks for tuning in. In this video, I am sharing my recent lecture on the updated brachial plexus anatomy, which was presented as a part of the IDRA 2025 online teaching module. So, without any further ado, let's dive right in. Today, I will be discussing the anatomy and the mechanism of the most commonly performed blocks in regional anesthesia, that is, the brachial plexus block. I bring warm greetings from Ganga Hospital, Coimbatore. Let me begin with a brief declaration. All the sources of photographs and the data have been appropriately cited and are accessible via QR codes embedded in my slides. Most of the illustrations and videos are my drawing or recordings, and the necessary consent has been obtained from the patients or volunteers. My journey in peripheral nerve blocks began in 2014 with an anatomical landmark guided subclavian perivascular brachial plexus block under the mentorship of Professor Vandana Mangal. I am sure many of you started your own journey with a brachial plexus block as well and can relate to the emotion behind the first successful attempt. Today, we will aim to deepen our understanding of the brachial plexus anatomy, explore its anatomical variations, and discuss how this knowledge can be effectively integrated into our clinical practice in the current era of ultrasound guided regional anesthesia. We will also touch upon the relevant microanatomy and the dynamics of the local anesthetic injections. So, various approaches using anatomical landmark, paresthesia, neurostimulation, or ultrasound guidance have been described in literature to access the brachial plexus at different levels. A useful surface guide is the brachial line or the line of Grossi, which runs from the apex of the scalene triangle, passes through the midpoint of the clavicle, and then middle of the chest wall and the coracoid process, ultimately reaches the pulsation of the axillary artery with the arm abducted at 45 degrees. The brachial plexus is a complex network formed by the ventral primary rami of C5 to T1 spinal nerves. Remember, these are rami, not the roots. Each of these spinal nerve also gives off a dorsal ramus. We will explore their course and the clinical relevance in my next class. Let's clear up the common confusion by revisiting the spinal nerve formation. Each spinal nerve is a mixed nerve formed by the union of the sensory afferent fibers from the dorsal root and the motor efferent fibers from the ventral root. After exiting the vertebral column through the intervertebral foramen, the spinal nerve divides into ventral rami and the dorsal rami, both of which are typically mixed nerve, with a few exceptions. Let's focus on this region of the upper trunk. Here you can see two nerves are converging, two nerves are diverging, and two nerves are emerging. This point is commonly known as the Erb's point. Injury to this point during the childbirth or trauma in adults can result in the Erb's palsy. A similar injury, when involves the lower trunk of the brachial plexus, we call it the Klumpke's palsy. Brachial plexus receives variable contribution from C4 or T2 and leading to aberrant motor or the sensory innervations. This can result in incomplete or atypical outcome of the brachial plexus block. Such variations, especially the post-fixed one, may be associated or may predispose the individuals to neurogenic thoracic outlet syndrome. The routine ultrasound imaging may not reliably detect such anomalies. In this case, the anterior scalene muscle is absent. The scalenus minimus muscle separates the subclavian artery from the dorsally located brachial plexus. Additionally, you can see a muscle bridge here which is connecting the scalenus minimus to the middle scalene muscle and running between the superior and the middle trunks. In this picture, we are seeing different positional anomalies of muscles and the ventral rami. So, is it possible to reliably identify the ventral rami using the ultrasound? The answer is yes, we can, with the background of anatomical knowledge and the static and dynamic scanning. On sonogram, the ventral rami typically appears as hypoechoic round structure with a hyperechoic rim. The transverse processes of the cervical vertebrae and the tubercles, they are represented here as the mountains. So the C5 and C6 ventral rami appears like a sun rising between two mountains. Anterior tubercle of the C6 transverse process is larger than the posterior one, which is also known as the Sessanic tubercle. For C7, the anterior tubercle is absent, so one mountain, and the sun rise above the sea for C8. As the straight hyperechoic line you are seeing here is the T1 transverse process first rib complex. The origin of the T1 ventral ramus can be identified in only 35% cases as it courses below the proximal part of the first rib. On dynamic scan can be visualized as it climbs over the medial border of the first rib to join the C8 ventral ramus forming the inferior trunk where it appears as if it is taking a U-turn. So this is known as the U-turn sign, which is a dynamic sign. In rest of the cases, it was a static sign. Recently, Dr. Manoj Karmakar and colleagues described all these neural elements similarly using a sequential ultrasound imaging technique or sweep technique by sweeping the probe in a cephalocaudal direction from supraclavicular fossa to the interscalene gap or groove. I won't go into the details here as you will have a dedicated class on the sweep technique soon. The choice of blocks depends on several factors, including the targeted dermatome, myotomes, and osteotomes, as you can see here along the course of the brachial plexus. The course can be described as a superficial part, which is mostly above the clavicle. Then there is narrowing to a pinch point between the clavicle and the first rib, forming almost an hourglass shape. The plexus expands at each end, but at the same time fixed to the intervertebral foramen and axillary sheath, making it vulnerable to compression, to injury, to surgical or the needle trauma. Are you still relying on these dermatomal bands to understand the sensory distribution? These bands doesn't represent the complete picture. Dermatomes are the areas of the skin innervated by a single spinal nerve, whereas the cutaneous innervation refers to the specific skin regions supplied by individual cutaneous nerves, that is, branches of the peripheral nerves. It comes from the nerves in vicinity. Several neural communications have been reported between the major as well as minor nerves of the brachial plexus with varying incidence. Understanding these connections can help us to explain the areas of sparing even after a seemingly successful brachial plexus block. These are the neural communications you can see in the proximal part of the arm. Neural communications also exist distally. For example, the Martin Gruber anastomosis, which involves the fibers from the median nerve proximally communicating with the ulnar nerve distally. Other communications like Ricci canu, Marianesi, Berrettini, etc. These are the types of anastomosis described in the literature with varying incidence rates. There is also presence of some plexiform communications, as for example between the posterocutaneous nerve of the arm from the radial nerve, axillary nerve, intercostobrachial nerve, and medial cutaneous nerve of the arm in the posteromedial aspect of the arm, which is not usually covered by the traditional brachial plexus block. So, what can we do to solve this problem? The simple local infiltration along the course of these communications, for example, from anterior to posterior axillary fold in case of surgeries on the anteromedial aspect of the arm, or a T-shaped infiltration along the posterior part of the arm in case of posterior approach to humerus surgery. The next option is giving complete limb anesthesia instead of site specific targeted nerve block, the use of secondary nerve blocks along with the primary blocks, and there is also supplementary and complementary blocks depending on the area of surgery and the incision. So we have identified the individual neural components of the brachial plexus. Now the question is, which of these contribute to the classic traffic light sign on the ultrasound? In 2008, it was proposed that all five ventral rami contribute to the stoplight sign. However, the cadaveric studies and high resolution ultrasound imaging have shown this is unlikely to be true. Later, in 2010, it was changed to C5, C6, and C7 ventral rami. But that is also not true always. Nearly 6 years later, it was correctly described as the traffic light sign consists of C5 as the red light, C6 appearing as two fascicles, the upper yellow and the lower green component. C7 may or may not align with this configuration. This can be correctly identified when we do a dynamic scan to locate the bifascicular C6 in the interscalene gap. Additionally, a muscular sleeve originating from anterior or middle scalene muscle is often interposed between the C6 lower fascicle and the C7 ventral rami. Clinically, this means that C7 may require a separate injection as local anesthetic administered around the C5 or C6 or the upper trunk may not always reliably spread towards it. C5 is significantly smaller than C6 and C7 ventral rami, and it rarely shows any macroscopic evidence of splitting. In contrast, C6 often demonstrate a macroscopic bifurcation into two fascicles, which is frequently mistaken for separate ventral rami as C6 and C7. This misidentification can increase the risk of unintended intraneural injection. Here you can see some more pictures of splitting. The left upper and the lower one are the C6 splitting before and after removal of the epineurium. Right upper one is the evidence of two splitting of C6, and the lower one is a rare variant with both C5 and C6 splitting. The next query is where to inject the local anesthetic. Shall we go for an aggressive intraplexus injection or a conservative periplexus injection? The literature, evidence, and the clinical practice suggest that both are equally effective to achieve the desired sensory and the motor block. Periplexus approach is less invasive and it also avoids the needle to nerve contact, which may reduce the incidence of nerve injury. Now, what is the anatomical relationship between the phrenic nerve and the brachial plexus? At the level of cricoid cartilage or C6, the phrenic nerve lies approximately 2 mm from the C5 ventral ramus. This distance increases caudally by about 3 mm for every 1 centimeter of descent. So, at 1 centimeter below the cricoid cartilage, the phrenic nerve and BP are roughly 5 mm apart. And this gap increases nearly tenfold when you reach the upper trunk area. On ultrasound, the phrenic nerve appears as a small, round, hypoechoic structure on the anterior surface of the anterior scalene muscle. Please remember the phrenic nerve, brachial plexus, and the deep cervical plexus all lie beneath the prevertebral layer of the deep cervical fascia. The ascending cervical artery is frequently seen accompanying the phrenic nerve at this level. Additionally, an accessory phrenic nerve is present in more than 50% of the Indian population. There has been a considerable confusion regarding the anatomical relationship between the suprascapular nerve and the anterior and posterior divisions of the upper trunk. The correct anatomical arrangements from craniodorsal to caudoventral is suprascapular nerve, then posterior division, and then anterior division, commonly remembered as SPA arrangements. The branching pattern can vary. The most frequent configuration involves all the three branches originating from the same point. There are presence of several neurovascular structures in the neck area other than the brachial plexus elements. For example, the dorsal scapular nerve, nerve to levator scapulae, the accessory spinal nerve or suprascapular nerve between the middle and the posterior scalene muscles. During PNS-guided brachial plexus block, the neurostimulation of these nerves can mimic the shoulder movements resulting from the deltoid or the biceps. For a successful interscalene block, we usually accept the muscle movements beyond the clavicle or anterior to the clavicle. The dorsal scapular and the long thoracic nerve courses through the middle scalene muscle. They appear as hyperechoic bands with hypoechoic fascicles within them. These two nerves are at risk of needle trauma while performing the lateral to medial approach of in-plane technique during interscalene block. I usually follow either out of plane technique or a steeper needle trajectory for in-plane technique to avoid entering into the bulk of the muscle. In addition, PNS here can help to identify these two nerves. The next intriguing question is about the brachial plexus sheath. Does it really exist? The answer is a definitive yes. The brachial plexus is enclosed within a paraneural sheath. However, its extent, continuity, and permeability can vary significantly. The initial cadaveric dissections revealed presence of an unorganized macroscopic fibrous sheath around the neurovascular bundle, which is filled with the loose connective tissue. Here, you can observe the bulging of the brachial plexus sheath in the supraclavicular area after 15 mils of saline injection. These findings can correlate with the visible fullness observed over the supraclavicular fossa following a subclavian perivascular brachial plexus block. Traditionally, this was considered as a clinical sign of correct drug deposition during landmark or neurostimulation guided techniques. Here, you can observe the axillary sheath enclosing the neurovascular bundle in a fresh cadaver dissection. This cross sectional view taken after the methylene blue dye injection shows the dye encompassing all the major nerves. On the upper right corner, you are seeing the magnified view of a cross section of a sheath just distal to the formation of the median nerve. The paraneural space is clearly visible here. Alternatively, the presence of sheath can be inferred from the retrograde spread of the dye from the infraclavicular region to the interscalene gap, suggesting that the sheath functions as a conduit. The clinical application of this concept has made the shoulder surgery feasible using costoclavicular block and has opened a new avenues for research into the phrenic nerve sparing technique for shoulder procedures. The incidence of phrenic nerve palsy is extremely low with the costoclavicular block. It was reported mainly with higher volumes of more than 25 mils. Now, let's find out whether we can identify the sheath with ultrasound and how it can affect our block technique. The paraneural sheath is visualized as a hyperechoic layer of connective tissue on the sonogram, which is distinct from the epimysium of the surrounding muscle, prevertebral layer of the deep cervical fascia, and the epineurium of the neural elements of the brachial plexus. An additional layer of hyperechoic connective tissue, that is the septum, is also seen, which subdivides this subparaneural compartment into an anterior superficial compartment which contains the divisions of the superior trunk and the posterior or the deeper compartment containing the middle and the inferior trunks and divisions. Once the sheath is identified, we can position the needle tip beneath it and deposit the local anesthetic. I usually prefer two separate injections targeting each compartment. There is no need to go below the plexus or the corner pocket area through the plexus. As the local anesthetic spreads, you will observe the plexus elements peeling away from the sheath. In this video, you can also observe a pulsatile dorsal scapular artery coursing within the plexus. In case of poor visibility, hydrodissection aids in confirming the correct plane and identification of the sheath. The visualization of the facial compartments and the neural elements improves significantly following the local anesthetic deposition, as you can see here. The immediate scanning of the costoclavicular space also revealed presence of local anesthetic following an injection in the supraclavicular fossa. Clinically, the subfacial injection results in faster onset of surgical anesthesia and prolonged duration of postoperative analgesia compared to an injection superficial to the sheath. Histological staining has revealed the paraneural sheath as a multi-layered network of collagen fibers interspersed with adipocytes. This sheath envelops not only the trunks and divisions of the brachial plexus, but also the subclavian vessels. The internal septum appears to be continuous with the adventitia of the subclavian vessels. Brachial plexus is highly vascular. The transverse cervical artery is more often detected compared to the dorsal scapular or suprascapular artery. It usually passes superficial to the scalene muscles and the brachial plexus. The dorsal scapular artery passes through or course around the brachial plexus. It can passes between the middle and the lower trunks or the upper and the middle trunks. The respective veins are also present there. So always use color Doppler to detect the vessels during the scout scan, which may be useful in reducing the risk of vascular puncture and last. Let's now focus on what happens to the brachial plexus as it passes behind and beyond the clavicle. Lateral to the first rib, six divisions of the brachial plexus regroup to form three cords and enter the costoclavicular space, which is located deep and posterior to the middle third of the clavicle, from where the cord descend to the infraclavicular fossa. This region is further divided into medial and lateral infraclavicular fossa. The medial part extends from the lateral border of the first rib cranially to the superior or the medial border of the pectoralis minor muscle inferiorly. Lateral infraclavicular fossa lies deep to the pectoralis minor muscle and in relation to the second part of the axillary artery. Within costoclavicular space, the cords are clustered together lateral to the first part of the axillary artery and lie between the clavicular head of the pectoralis major muscle and subclavius muscle anteriorly and the serratus anterior muscle overlying the second rib posteriorly. The lateral cord is most superficial and the posterior cord is most lateral here. If you visualize the cephalic vein or the thoracoacromial artery and its branches on ultrasound, it indicates that you are scanning beyond the costoclavicular space. Similar to the supraclavicular region, the paraneural sheath at the costoclavicular space appears as a hyperechoic connective tissue layer on the ultrasound. It is positioned between the epimysium of the surrounding muscle and the outer surface of the brachial plexus cords. A single septum is also present here, which divides it into anterior compartment containing the lateral cord and the posterior compartment containing the medial and the posterior cord. Here also, we perform two injections, one for each compartment. While injecting local anesthetic in the posterior compartment, try to avoid pushing your needle tip between the posterior and the medial cord. The cadaveric studies have demonstrated that they are intimately adherent to each other. Separating them may result in nerve injury. The sagittal sonogram here showing the medial infraclavicular fossa, which is immediately caudal and lateral to the midpoint of the clavicle. The cords are clustered together above the axillary artery in a triangular costoclavicular space. Rest of the things are similar to the costoclavicular state as we have discussed. At the lateral infraclavicular fossa, each cord takes up the position around the second part of the axillary artery. Usually, the posterior cord lies at 6 o'clock position, medial cord between 2 to 4 o'clock, and lateral cord between 9 to 12 o'clock position. But this position of the cords is highly variable and also affected by the abduction of the arm. The anatomical arrangements of the paraneural sheath and its facial compartment at this lateral infraclavicular fossa are similar to the costoclavicular space. The microanatomy of the brachial plexus here also similar to the costoclavicular space as we have discussed. In some cases, musculocutaneous and the axillary nerve branch off early from their respective cords, which may lead to incomplete coverage with a lateral infraclavicular block and result in sparing. In retroclavicular approach to infraclavicular block or the raptor approach, the needle passes through an acoustic shadow behind the clavicle. Suprascapular nerve and vessels are vulnerable here to injury because they are located along the needle trajectory. Neurostimulation during the needle advancement and monitoring for external rotation of the shoulder may reduce the incidence of inadvertent nerve injury. At the level of the axilla, the median, radial, ulnar nerves lie in close proximity to the third part of the axillary artery within the axillary sheath. Here, the sheath may have multiple compartments around each nerve, which becomes evident after injection of local anesthetic. The musculocutaneous nerve generally lies outside the sheath and within the substance of the coracobrachialis muscle. Please remember, at this level, musculocutaneous nerve does not lie between the coracobrachialis and biceps brachii muscle, which is mentioned in many articles and even textbooks. There is a large degree of anatomical variability with respect to the cords around the artery or the number of veins or position of the veins. Hence, a dynamic scanning is needed to locate the nerves and also use the color Doppler to identify the blood vessels around the plexus. It is so variable that I usually tell my students that your next axillary brachial plexus block will be different from the current or the previous one. For further reading, you can consider these two books. To conclude, we have explored the updated concept in brachial plexus anatomy, including its variation, microanatomy, and the sonoanatomy. I hope this knowledge will be helpful for you to guide you in block selection, refining your injection technique, avoiding complications, and effectively troubleshooting the failures. All are the essential steps towards mastering the brachial plexus block. Thank you so much for your kind attention. If you have any queries, please ask me or you can write in the chat box. I will try to answer them. Thank you.